All right. David, do you want to introduce
Certainly, yes. My
Jared?
name is Peter, for everyone who doesn't know me. We're at the Addiction Medicine Fellowship here at the University of Minnesota. This is the Journal Club, kind of combined with this fellowship program with the Minnesota Society of Addiction Medicine. And Pam Schultz has been kind of running this and has allowed me to join her in this. And today we have a current fellow, Jared Hopkins, who's an emergency medicine physician, presenting on a topic for us.
All right.
And
Hey,
you
welcome.
see the slides, right? Yeah,
Yep.
good, okay.
Okay, we'll go ahead and get started. I'm going to hit you guys with somewhat of a wall of text in some of these slides, so I apologize. Just the nature of the paper made it a little difficult not to, but we'll be talking about you can see the title on the screen here, but it's a consensus statement.
Can we get rid of this? Oh, you're gonna,
Oh yeah, can you, because you guys want to see,
yeah,
well, I can try to make,
I can click out of badge.
Um, can you see this? Is that big enough? Or here I can just do it without presenter notes. Let's see if this works. So it's a consensus statement on pain management for pregnant patients with opioid use disorder, which is really the first time this has ever been done. And we'll talk a little bit about the history of that. And then I've already been introduced. I have no disclosures. And so here are just a few learning objectives. We'll talk briefly just kind of about peripartum pain, why this patient population is somewhat unique, and review some of the specific new guidelines in the consensus statements. And then a little bit about where research is lacking, which, spoiler alert, is in most areas. So the research question, I guess it's not so much of a question as it's just a reflection that there's really not a ton of data for this specific patient population and how to treat peripartum pain. And as such, there are not great protocols or evidence-based recommendations. And so the goal is to remedy that a little bit. And this was a collaboration between these organizations, the obstetric anesthesia and perinatology, MFM, and then I think this stands for American Society of Regional Anesthesia. And so the way this all came about, it really started before the current paper with this scoping review back in 2022, where they basically looked for all literature in pregnant patients with opioid use disorder, basically throughout all time and all languages. And I'll show you some of that in a minute. And then from that, developed a working group to identify key questions. And then from that, developed smaller working groups, specifically for prenatal optimization, labor, and post-delivery pain. And they use the ACC and AHA clinical practice guideline classification system, which somewhat convoluted. Maybe you're all more familiar than I am. I'll show it to you just for reference here in a second to try to base these recommendations off of. So in terms of the scoping review, this is what it looked like. So they found 994 studies initially with further screening and ended up with 84 studies included in the final paper and recommendations. To give you an idea of the scope. I found this kind of interesting just as kind of a spread of the quality of the data from the original meta-analysis, which is, I think, overall it just shows that in terms of the research pyramid, there's a lot of lower quality evidence and not a ton of high quality evidence available.
Jared, can you make the slides any bigger? They're hard to read.
I don't know.
Well,
No,
I don't know.
No, I'm sorry.
Control plus.
Hold on, let me try that. Somebody said Control Plus. No, I don't think that did anything. I don't know. I think we're stuck.
Okay.
Sorry.
Just talk through that and kind of
Yeah.
highlights. Yeah.
And then I just included this too to show. I also found this interesting, just the kind of spread of through time of the available literature. And obviously it shifted much more towards recent times. And I think that makes sense in terms of the opioid epidemic to see more research through time, but also I think was just slightly reassuring that we're looking, there more studies are coming out, and I don't know, I just found this kind of interesting to look at the time scale of the available literature from the scoping review. This is the level of evidence that they use. Sorry, and you're not gonna be able to read this at all then if you couldn't see the other things, but it's not terribly important because you can't memorize it. And it really, there's the strength of recommendation and the quality of evidence. And so I'll include some of that in the individual recommendations when we get there, but it's not terribly important. But suffice to say, it's all on the lower end of strength and quality. Just pain in general, we won't talk a ton about this, but I think it's important to note that both pain and chronic pain and addiction both have a lot of biopsychosocial aspects, and we'll talk about some specific ways that applies to the pregnant population with opioid use disorder. But it's a very complex for multiple reasons in this patient population, and this goes without saying, but labor is very painful. And I found this in a pain journal that used this McGill questionnaire for pain scores for different painful conditions, showing how high up labor is in the non-chronic opioid or opioid use disorder patient population. These are just random thoughts I had, so there's no title for this, but I think just reflecting on why it's a unique patient population in general, patients are very worried their pain is not going to be treated adequately, especially when they come in with opioid use disorder. I think this is true a lot of times. Doctors are worried they're going to make things worse by giving opioids. I think we've created some problems, obviously, and sometimes this can be true, and we have to individualize the approach for these patients and make sure they're informed and on board with the plan. But this is a real worry, and patients' pain is undertreated when they come in with opioid use disorder. I think we've probably all seen this. This patient population has increased morbidity and mortality, numerous studies showing this. And we talked a little bit about this, but there's just not a real streamlined approach in most places for treating patients in this patient population. And there are some things that are in use that can be adapted, which I'll kind of show some examples of these, especially with post-operative pain.
One quick note I want to make.
Yeah.
You mentioned here that physicians are worried about exacerbating OUD. I think patients also. The
Yeah.
mothers themselves often
Definitely.
don't want to have their kids have opioid withdrawal symptoms, and so they will intentionally decrease doses during third trimester, which is, you'll probably get to that, but yeah.
Very true. Just going over a few things that are currently in use for kind of post-operative optimization of pain, not specific to opioid use disorder, but there's the ERAS protocol, which is kind of widely used throughout surgery, which really makes sense. Things like scheduling NSAIDs and acetaminophen, adjuncts to pain that are non-opioids, early mobilization, and some other things. This is not unique to this patient population, but should be considered as part of the treatment plan. And more specific to pregnancy, this is used in some facilities, ERAX. And I think the kind of important points are, again, planning, scheduling, things like NSAIDs and acetaminophen, opioid sparing medications, early mobilization. And so these are kind of protocols that are already out there for just general population that just to make you aware of. So in terms of the first kind of working group, prenatal optimization, I think the big points here are, for me at least, this patient population has a lot of comorbidities, both in terms of other substance use, things like nicotine and alcohol, as well as mental health conditions, depression and anxiety. I don't have my notes up, but there have been several studies showing that like comorbid anxiety, I think, was somewhere around 50% of pregnant patients with opioid use disorder. And both anxiety, depression, and nicotine and alcohol increase pain scores postoperatively. And they tend to be associated with increased opioid requirements. And so I think that's kind of one thing to think about in the prenatal period when planning. And then kind of what we should be thinking about when planning, if we have the opportunity to meet with patients before they go into the hospital to deliver, which is not always the case, but I think just simple things like reviewing their current treatment plan and confirming doses and trying to coordinate with their outpatient team if possible.
So 21, North Building.
Early
High
consultation
two,
with other
first floor.
specialties, which we'll get into, but
21,
OB and
North
MFM,
Building, high
addiction
two.
medicine,
Or
pain medicine. Sometimes it's necessary to speak with social workers, caseworkers, CPS. So just considering that you may need to kind of coordinate as a team. And then coordinating with the patient. This is kind of Dave alluded to this. Patients have had a lot of positive or negative experiences, some positive experiences for things that have worked. I think it's important to talk to the patient about what has and hasn't worked in the past and kind of frame our treatment plan around that because they can give us a lot of direction, I think.
code 21, North Building, high
and
two, first floor.
Just their general fears
Code
about
21, North Building,
their
high
pain
two,
control,
first floor.
the effects
Code
on
21, North Building, high
the
two,
child,
first floor.
and sorry, this announcement is just overpowering. And just coming up with a good trauma-informed plan with the patient, and then also making sure that the plan extends beyond the labor and delivery to what happens afterwards. Are they going home on opioids? Are we going to taper those? What impact is it going to have had that we gave them opioids in the hospital? We have to make sure they're aware of like a potential positive urine drug screen and so on. And we'll talk about that again. But I think just patient education, making sure they're fully informed on the plan is important, and also staff education, both from the physician side, but also nursing. So this is an opportunity to discuss with the rest of the team and make sure that everyone's on board and educated on appropriate pain management. So diving into some of the specific clinical recommendations from the paper, and some of the specific questions and the recommendations. So one of the first ones for prenatal optimization and planning was anesthesia consultation. And this is the question you can see, which is essentially, should we be getting these consults on all patients if we have the opportunity? And I think the answer is yes. And that's, again, you can see there, the level, the strength of the recommendation below is not super strong based on the available data, but I think we can all agree getting anesthesia on board for both a pain management plan and helping to address fears and concerns for the patients is important. And also important to know that there are several studies showing that patients with opioid use disorder or just chronic opioid requirements in general are going to have higher neuraxial requirements and higher opioid requirements post-operatively. And so it's important to get our anesthesia colleagues on board. So the answer to that question is yes, we should consider getting an anesthesia consultation. They delve a lot into the different medications and kind of how to approach those in pregnant patients with opioid use disorder. And so methadone, I think probably a lot of us already have a framework for this, but should we split, continue, increase, reduce, or stop methadone? Generally speaking, it should be continued. We should continue. We should consider splitting the dose. We should consider that they may need a higher dose. Part of this is things like volume distribution. Part of this is increased cytochrome expression, but typically we would expect to go up on the dose and require splitting the dose as we get closer into the third trimester. This was a statement that
Code 21, North Building.
they put in the
patient
paper
12, first floor.
that it's not
high
possible to
two,
rapidly titrate.
code
And I think if the
21,
patient's hospitalized and are
Building,
initiating
patient
methadone,
12,
sometimes we have a little bit
first
more room
floor.
to
high
titrate it
two,
rapidly in the
code
early stages.
21,
But
North Building,
I think just
patient 12, first
in
floor.
terms of framing
high
this as a
two.
prenatal optimization, it's a good time to consider kind of the dosing plan before and following labor. And then just to note that you can still use short-acting opioids. I can tell you that when I am on inpatient consult service, a lot of times these are not given to patients with painful conditions because they're on methadone.
Code
And
21, North Building, patient
I think
12,
this is just another good
first
reminder
floor. high
to
two,
come together as a team
code
and make sure all
21,
staff is educated and
North Building,
that they may need
12,
additional or sometimes
first
higher
floor,
doses of opioids in addition to their methadone.
421, North
Um,
Village.
Same
Station 12,
question for
first
Suboxone
floor,
or buprenorphine.
high school.
It should be continued. It's metabolized similarly, and it's worth considering splitting the dose, both for pain and for their maintenance for OUD. And we may need higher doses. Naltrexone, this is a somewhat of a tough one. So same question. The big recommendation is if you have time, you should consider switching off of naltrexone. It makes pain management difficult. I think we all know that. Sometimes that's not the case. Sometimes we don't have the opportunity to make these switches in time. But if you can, then I would consider switching. Their recommendation was to stop oral naltrexone at least 72 hours before labor, delivery, or C-section. That's their recommendation. And ideally at least 6 weeks for the long-acting injectable if you can. If you can't, then a multimodal approach, which should be used in general anyway, is important, but it can be tough to control their pain. So non-opioids, I mean, I'm an ER doctor, so I use a lot of ketamine, but this is a decent use for ketamine for pain. And so another importance of having your anesthesia and pain teams on board. There's a lot of talk in the paper about kind of additional therapies and their usefulness, things both on the mental health side, like therapy, but also for pain. So in terms of birth planning, water immersion, music, there's not great data on this. I don't think that's a surprise, but I think, again, this is a case where it would, given the degree of comorbid conditions, I think we should be equitable. We should give them anything we would give patients without OUD. But I think we should really throw everything we can at them for support. And so if these things are available, I think they're worth considering. There's just not great data on how effective they are. There's some data on aromatherapy, however, so that is widely used, at least here. And I already said that. So withdrawal, some of this is just my rambling, some of this is in the paper. We shouldn't be reducing these medications typically. Monitoring for withdrawal, this is, I think, an important one. I don't know how many times I will show up for a consult. The patient came in for labor and delivery the day before, and I see them and they're in Florida withdrawal. People are scared to initiate the appropriate medications or escalate the doses, and they need frequent monitoring. It's okay to treat with most of the standard therapies, which we're all familiar with. They work to varying degrees, but I think any of the support and comfort medications can be used. And then having a plan for patients who are not on a maintenance therapy is important. I think this was quite common, at least around here, in patients coming in with no prenatal care to deliver, and they're in withdrawal, they're having horrible, painful condition, and I think it's important to both have a plan for treating patients on maintenance therapy, so the prenatal planning, but also having a plan for patients that are, including full agonist opioids to treat the withdrawal and pain. You can consider things like microinduction of buprenorphine alongside of that, or methadone, but I think just this is something that people need to be slightly more prepared for, and we should have a plan for. Shifting a little bit to pain during labor. We've talked about some of this is somewhat repetitive, but they have increased pain needs, typically speaking. And we need to, I think a good starting point is going to be offering them the same pain management that we would offer patients without OUD, and then expecting the need to escalate doses or frequency of medication. But being equitable, I think in terms of what's offered is kind of one of the important takeaways from all of this, and then escalating. Multimodal approach, we'll talk about some of those in more detail, but we talked about it some already. And there's really, unless it's specific to the plan you came up with the patient, there's not an inherent need to avoid opioids. Continue their medications if you can.
This is that education piece there too, the last one you had there. If they do require opioids, they often require a higher dose
Yeah.
if they're have a high opioid
Yeah.
tolerance, either from fentanyl use or on buprenorphine, for
Yeah.
instance. That's in nursing, often education.
Yes, that is, yes, agreed. Again, with monitoring,
Well, in general, people, healthcare people who aren't trained think, oh my gosh, the patient has opiate use disorder. We can't use any opiates, right? Or we shouldn't give them any opiates. That's their, which of course, the opposite is true, but
yeah.
Um,
And then when they are given, a lot of times there's the impression you need to give lower doses, which is again,
right,
the wrong direction.
I'm worried they already have opioids on board. I'm gonna do harm by giving them more.
Yes.
So they-
right.
Yeah.
I've noticed, I don't know, has neonatal absence syndrome been brought up at all yet in the conversation?
No, I don't know that well. So bring it up.
I found that there's a decent amount of time where patients are really worried, or patients are worried hearing about it, but also there are some providers that may not be in obstetrics, like a lot of pediatric providers may be very hyping about the severity of neonatal abstinence, but my understanding is that it's usually a it looks very disturbing because there's a lot of shaking and things like that, but it actually is pretty self-limiting when given appropriate cares. And so I know that there's some people who will try to reduce it for those reasons.
That's what I mentioned. Patients unfortunately are worried about it and they will lower their own buprenorphine dose in the third trimester, which is the exact opposite of what they often need
Yeah.
physiologically.
Yep.
Because they want to reduce the risk of that. And the general counsel is not to do that, because risk of relapse.
Yeah.
And that
Right,
has a little less neonatal withdrawal, opioid withdrawal syndrome than methadone pound. And they're also finding strategies now to do it without even giving opioids as much. They found soothing strategies, rooming in with the mother, quiet lights. A lot of those actually mean they don't need that much medication. for the
Skin to
child.
skin, those
Yeah.
sorts of things.
Exactly. So
right.
I thought it wasn't dose dependent. as
it's
well.
not as much now. And buprenorphine seems to have less than methadone. And it doesn't seem to be all that dose dependent. So that's why we generally counsel don't lower. In fact, they may actually need higher, but patients will lower on their own sometimes due to fears of that. So it's a good point, Chris.
And yeah, I think this is in line with what you guys are talking about as well. Just when we don't adequately treat pain or withdrawal, people disengage from care. They're worried about coming in for care. They're less likely to continue with their maintenance therapies, and so we should really just make all efforts to control their pain and withdrawal. I think that goes without saying. And we talked about staff education. Those are my musings. So in terms of neuraxial anesthesia, its specific requirements, it's recommended. I think it in general, it's been shown to be, in terms of systemic opioids, opioid sparing, and we should start with the standard dosing and standard approach. And this is, I think, a good starting point for most things, anticipating they may need higher doses, or maybe a different approach to which opioids we are using, if we're using opioids in the epidural. But a good starting point is just standard dosing. That's their recommendation. You should not routinely omit opioids from the epidural solution. But we got to talk to the patient about it. And I think I had alluded to this before, but giving patients opioids in the hospital can have big impacts when they leave, depending on their situation. And so it's important they're aware of what they were given and that they're counseled appropriately on that. So for non-opioids, an epidural solution, should we consider them? I think most of us are anesthesiologists, but when we're talking with the anesthesiologists about these patients, there's limited evidence. There's most evidence for clonidine, but there's a black box warning for hypotension in pregnant patients. And so it's an individual approach is required here, but yeah, there's no reason not to hold back on giving additional non-opioids, especially if we're holding opioids out of the epidural for some other reason. So there are options, including Precedex, ketamine, epinephrine, clonidine.
The black box is just for clonidine, not for Precedex.
That's what I believe. I have to double check, but I think so. And I think it's mostly for hypotension. And then the other options, again, we should just offer patients, typically what we would offer patients without OUD, but there are things like nitrous. This can be a little bit, I think I put a note in here. If they come in with recent use, you have to be particularly careful of sedation in this. And so nitrous is not always a great option if there's ongoing use. I talked to one of the OB doctors here, and it's not routinely used in this hospital because they can't monitor effectively enough in this patient population. But if there's appropriate monitoring, nitrous can be offered. Opioid PCAs individualized as you would for patients without opioid use disorder. And then the paper did mention that in terms of which substance to use, sufentanil is and hydromorphone both tend to, I think, be the preferred.
They'll compete
agents.
better with buprenorphine
Yeah.
than some other opioids. So if you're gonna choose one and someone's on buprenorphine particularly, they have a higher affinity in that sense. So they're closer to buprenorphine that way.
And then this, of course, would be if you cannot do neuraxial analgesia. Ketamine, again, I love ketamine for my other job, and so I like to talk about it, but there's fairly limited data, especially on the neonatal and lactation side of things. And so it was a lukewarm recommendation to consider it as part of your multimodal approach, but it is an option and it is used. Things like lidocaine patches, and then we talked about some of these other treatments. So then shifting over to the specific recommendations for post-delivery, this is all fairly similar to all the previous slides, which is you should continue their medications. You should consider multimodal treatment, uncoupling NSAIDs and Tylenol from the opioids if you're using those. And then we'll talk about specific approaches to extending the epidural. And so this question was, should we consider keeping the epidural on longer? And so the recommendation is it be considered for 12 to 48 hours. This kind of goes against some of the other recommendations, such as early mobilization. And so it needs to be, yeah, there, I put that in there, individualized. Most places are offering regional anesthesia and blocks, which I'll have a slide on, things like tap blocks, which are really opioid sparing, in which case you typically wouldn't need to consider extending epidural analgesia, but it is an option and it is done. Sometimes I spoke again with somebody here, they'll keep these going for 24 to 48 hours for if needed. There are a lot of blocks. Tap blocks are the most common. These are, I can't remember the exact number now, but I saw one paper, I think it was 60% reduction in opioid use in patients that got tap blocks post C-section. I think that was in general population. There are numerous other blocks. There's that are options both from the anesthesia side and also from the OB side in terms of wound infiltration, single injections, and continuous infusions. Less data on most things than tap blocks, but these are strongly recommended. Yeah, so what do we do with their maintenance medications after delivery? Well, we should continue it if possible. They continue to recommend splitting the dose following delivery. For how long, I don't think anyone knows. I'd be interested to know people's approach to when you go back to standard dosing after delivery. In terms of metabolism and volume and distribution, I don't know. I've never known when to consider going back from, in the third trimester, we increase the frequency and the dose. When do we go back? They didn't really have an answer. I've not found any compelling data. If anyone has any thoughts on when you would typically start going back to their pre-third trimester dose.
If I recall correctly, in one of the educations we had from 1 to 3, there was a provider who keeps it for like 6 to 12 months afterwards.
That's a long time.
Yeah, it's a long time.
I've seen more like 2 weeks.
Yeah.
Yeah, I don't know if there's data on this, I would think.
I didn't find
Yeah.
any, but.
Charlie told me it was about 2 weeks.
Yeah.
And Abby puts in her little doc phrase, 3 to 11 months. So she must have. found
That's
that somewhere.
where, that's I think where the, is from that provider, so.
Okay.
Well,
We'll have to look into this, but yeah, we don't have a clear consensus, it
So-
sounds like.
So yeah, this
Yeah.
is like one of the areas that
Yeah.
kind of stood out to me as there's just
Yeah.
really limited data, but it's something that comes up a lot, so, oh yeah, there we go, I just talked about that.
But I feel like too, all the patients I've seen haven't truly been at stable dosing where they're going up in their 3rd trimester. Everybody's kind of on like an upward titration throughout their pregnancy, and they never have like a true like stable dose, at least from what I've seen. I don't know if you guys.
Yeah, I've run into some issues post-delivery in terms of sedation and stuff too, so they'll continue their dose, they'll deliver, they're also getting additional opioids for pain, and I'll see them in the morning, they're quite sedated, and then it's, do we reduce the methadone, or do we reduce the short-acting opioids, and so that's something I've run into a few times, and.
If you think about the volume changes and stuff that occur in pregnancy, that's split the dose, right? And, especially in the last trimester. So, I mean, those revert pretty quickly after delivery. I mean, within a couple weeks. So you'd think that you could go back to single dosing. I mean, just if you think about it in that regard.
Right,
Yeah,
yeah.
Could you go by some of the literature that's it's used to monitor when rifampin doses are adjusted back to normal for TB patients?
Mhm. Is that change due to volume changes, Cole? Or rifampin?
Good question. I'm not sure. It
Mhm.
has the same metabolic route.
Huh,
But I'm not sure about the volume changes.
okay.
consider that. It's interesting question. And then a lot of this, sorry with the ketamine, and I can't help myself, but it's an option. Gabapentin was kind of interesting for me because it's used fairly widely in this hospital. But the paper, I mean, there's fairly conflicting data on whether or not it is opioid sparing, especially in patients with opioid use disorder. I don't know. There's also limited data in terms of neonatal side effects. It is, I think, worth considering, and it is used in this facility. The paper had kind of, they can't recommend it, but didn't strongly not recommend it.
Did you see anything about PO ketamine or was this all IV administrations?
It was all about IV that I looked at. What do you have thoughts on PO ketamine?
I use it a ton. That's all I use mostly because that's all it's available in most stuff floors that we have. So outside the ED and ICU, or even in an outpatient setting, it's the same formulation as IV. A little bit different dosing, but relatively cheap and not quite as good as IV from experience, but way easier.
Yeah, I've never used PO ketamine, but I think it's having a view on your rotation. So, yeah, no. Well, good to think about. I've honestly never thought
Interesting.
about it as an option because I've just never used it, but it's good to.
Are you talking about like the troches or troches?
No, just it's the same formulation as IV. Like there's 2 different ways you can give it orally. There's one is just the IV formulation.
Okay.
Just given as a PO solution, which is usually the easiest and cheapest. And then down in California, they have a different formulation I think you're talking about that like Andrew Herring and that group has used. But
Northwest too, they've used it for
okay.
induction protocols, but they had to get it like from a specialty pharmacy. I was curious. Gotcha. So you're just using the IV formulation, just giving it orally.
It still needs to be compounded, yeah, but it's relatively cheap. I mean, it still works and it's yeah. That other option was just way too expensive.
So
I don't know if my microphone is working. Can you guys hear me?
It is.
It is.
Perfect. So oral ketamine is available through Health Fairview hospitals. It's basically the pharmacy is taking the injectable, putting it into an oral solution syringe for use.
Solution. Okay.
Okay, so
There are also policies, procedures around use of the IV product too on general care floors. So it's not completely not available, but there's just some guidelines around its use.
Good to know. Thank you.
yeah, good to know.
I'll get you guys with
It's okay, that's good.
Jared has a disclosure about stock and
That one should have been at the beginning of this.
Yeah.
Yeah, my disclosure. Yeah, I have no disclosures by the way, not for ketamine either. Outpatient plan. I think the big question here is regarding sending patients with opioids after delivery and they go home. These are rarely used after vaginal deliveries in general. If they would be required, if they did not have OUD, then they can be considered inpatients. So if OUD, if it's in line with, their goals. Again, patients postoperatively anticipate needing higher doses. And then this was not in the paper. This was because I asked one of the OB doctors here what they consider a high dose of short acting opioids and when they would worry about things like neonatal sedation. And they found one paper they sent me which quoted this, that they need extended neonatal observation if they're getting more than 40 milligrams of oxycodone or equivalent in 24 hours, which I thought was kind of interesting. There's very, very limited data on this, but there's at least one paper that I got this quote from.
So like 60 MME equivalent or the math?
Yeah, something like that. And we talked about coordination with outpatient teams if we can. Don't forget a bridge prescription, don't forget Narcan, simple things. Again, some of these are just my thoughts. Harm reduction, fentanyl test strips, education, kind of community resources before they leave. It's easy to, I think, for them to fall off our radar once we make the initial recommendations. And we're getting towards the end here. These are just things I found kind of interesting. I did run into this one time at Abbott, which I guess I'd forgotten from med school that obviously this can be an issue with opioids in general, but especially epidural. And they use Nubane or other partial agonists to treat this. And so we had a patient that went into pretty bad withdrawal that they were stable on. I forget which they were on, but then they were given this for their itching and went into pretty severe withdrawal. And it was part of the labor and delivery protocol. And so it was never on my radar, but now it is. And so this was a recommendation in the article. It reminded me to bring this up. But
so much is used like even naltrexone for
yeah, that's right.
Yeah, so I can see why. Yeah.
And then considering the serotonin receptor stuff like Zofran is used and can be helpful with itching. Again, something that I guess I maybe at one point forgot, but this was a recommendation to consider other agents. And then we talked about this already, but I always worry a little bit about patients receiving things and not being counseled appropriately and that having downstream effects when they.
Well, they're involved in the carceral system under kind of probation, I wonder too. Yeah, I wonder if it's ever happened. I'm sure it has.
Talk about that. All right. We talked about the paper. I think it's a good first collaborative step. There's a lot of room for research as evidenced by our discussion and the kind of strength of the available evidence. And I think obviously we can't meet and plan effectively with every single patient before they go in to deliver, and that's just not practical, but any planning and collaboration with kind of the rest of the team that would be relevant, important, and trying to standardize approach the best we can. I love things like order sets as a starting point, but just kind of having a standardized approach in how we treat pain in patients on maintenance therapy or currently using opioids or illicit opioids is important. And we talked about that. And those are my references. That's all I got. Sorry, it's 29.
Super.
I tried to condense 29 pages of recommendations the best I could. It's a lot of text.
What is standard, does anyone know like the standard length of opioid prescription for post C-section?
Yeah, it's around 5 days typically here, I think.
Okay. Just curious, because as someone who's want to watch, it doesn't extend by accident, because some people prescribe way longer than they should post-op. And people with MOUD want to be a little more careful that they're not just given like a month's supply and sent home and no problem. Just,
Yeah.
bad things could happen.
Yeah, I think
Fair.
it's a good point. They may need higher doses, but the duration should be the same.
Short with most follow-up. And if we somehow do need to extend, it needs to be really clear. We're gonna taper back down and not give you too long at once. Yeah. Just so we don't accidentally cause harm.
Good point.
Your naltrexone patients. So I seen like the infusion center that they always say like provided patient with like the naltrexone card that says that they're on that medication. Have you seen patients in the ED? Like, will they give you that card saying they're on a medication like that, or do they
Never.
know they're on the medication?
Never.
I
The
figured
answer
they
is
wouldn't,
never.
but
Thank you for saying that.
Never, yeah. I
Not
wondered
once.
about that, yeah.
Not once.
Yeah, I can't imagine.
Yeah. And I found out the hard way when like nothing is working.
Sure.
And that's how I figured out, because then, like we don't, ER doctors don't like to look in the medical record, but then like something's not working, and then that's how I find out. The patient doesn't know.
Yeah.
Yeah. Question in the chat asking about the logistics of split methadone dosing as far as the OTP goes when a patient's pregnant and requiring that. Are there any limits, or, are they able to accommodate that? Do you know anything about that?
I don't.
I mean, it depends on the OTP, but they definitely can do split dosing, and they do it already for some of their higher dose patients, a lot of centers. So I imagine it shouldn't be a problem if they're getting take homes. It just probably depends.
Oh,
on the
I
center.
think it totally depends on the OTP clinic.
Yeah.
It's
Yeah.
their staffing. I
Yeah.
wish we had that. We don't have that availability up here.
yeah, if they're on take homes, I guess then that's easy for them to do that.
For instance, the VA where I work also, they definitely do split dosing. For patients just on higher doses sometimes anyway, so it's not a problem.
So they come in twice a day, or they're
They
on
use
take
take
home?
homes that way too, yeah. Only people who are on more stable and doing take homes.
Mhm.
I asked because, I mean, it's allowed, there's guidance on this, like there's some exception form or something, check this box, but I'm always floored sometimes by, when I think there should be take-home doses allowed and how restrictive sometimes it appears the OTPs are, so. I was just curious if this is a barrier or just how easy it is to have that second dose.
Yeah. I think, as I recall, we sometimes put pregnant women on more take home than what they, made an exception so that they could dose themselves, then do a split dose at home. That was years ago when I was working in a methadone clinic, but now it should be even easier because the take home rules are easier, so, or I guess more flexible. Could you go back, Jared, could you go back to that methadone, the slide you have that says methadone? Where you were talking about I had a couple questions there.
Were there any more questions in the comments? Sorry, we don't have the comments.
Yeah, we
open.
don't have the comments up.
What's
Was
that?
Was that the
Oh,
only-
no, that's the only one I see. In the chat?
Yeah.
Oops, wait, I think you passed it,
Oh, was it in here?
didn't you? Isn't it after the,
Did I? I think I had, the first methadone was under prenatal, I think.
okay,
I mean. Yeah, there you
oh,
go.
yeah, here, yeah, who's monitoring that, when they need higher doses and all that. That was, I guess, one of the questions. I think, you know, like, how closely is the OTP adjusting those doses? Is the obstetrician recommending adjustments? You know, I think that's hard, and probably there's not good coordination a lot of times, I think. But I think the other thing I was gonna say is that how effective are those short-acting opiates gonna be if patients are already on, high doses of methadone? That's another question. So, I mean, how do you really expect that they're gonna get much additional effect from the short-acting opiates?
Yeah, now with the standard dosing, which we're almost always getting, I think anecdotally, yeah, I mean, I think when we go like 2 to 3 times the normal amount, then they at least, I think, get some response. But yeah, it takes much higher doses, and I don't think that's commonly done in the hospital. Like, I'll look and they're getting 5 milligrams of oxycodone every 6 hours. Like, I don't think they're feeling anything.
Yeah.
But
Right.
triple it.
Right.
But it takes so much convincing the primary team and nursing to give those doses.
Yeah, it does.
I think there really ideally needs to be sort of a coordinated team, for these patients, because I mean, it really does take like an addiction medicine input. It takes the obstetrician's input. It takes, perhaps an anesthesiologist's input, and, along with nursing, and that is it's hard to do.
Like we need another order set
Yeah.
for patients that are on OUD coming in. Here's your order set. This will look differently.
But even if you have the order set, if you have somebody come on shift overnight who's just not familiar with this concept, they'll see the dose and get really, really worried and just won't give it. So I mean, it's, a lot of education.
Yeah. And, you mentioned staff education. I think patient education is also really important. Like you said, they may think, oh, I need to reduce or stop my methadone or my buprenorphine because of the baby, or something. So there really needs to be a lot of education with the patient.
Agreed.
Okay, thanks. Anybody else have questions? Yeah, it's an interesting topic and definitely challenging to manage these patients, that's for sure.
Is there any comparison on if you're gonna start MOUD for a preference of methadone versus buprenorphine?
No, so the outcomes are similar. Again, limited data, but the outcomes are both in terms of pain levels and also, I think it looked at mortality specifically. I don't know the time frame, but we're similar for the two. There was no preference.
Are you starting it for OUD? Or are you starting it
For OUD in the setting of like, they're coming in an acute withdrawal,
Yeah,
just find that methadone can be kind of faster.
I would probably do methadone in that scenario if you're looking for really sort of rapid control, to get it more rapidly.
I'm guessing.
With
it's
but
not-
I think there's some evidence that buprenorphine causes less problems with neonatal abstinence syndrome after delivery than methadone.
That
Assuming nobody's
fetal.
tried
Little.
these like macro inductions on pregnant people yet.
Yeah, it's tricky.
Methadone, the fetal health, I don't know.
I go normal. Yeah.
Yeah, it's not a problem.
Yeah.
Like, we're just straight out first injection. Yeah, I've never done it.
Yeah, I think I've always just used normal approach. Like, we'll go, like, I've gone up to like 60 over 2 days.
Yeah, okay. Like the general tolerance, so basically giving themselves already. It's really high there. Yeah.
One last question, Jared, why did you choose to show a forceps delivery picture.
I-
In
I
your
Googled-
labor slide.
So two reasons. One, I Google image search painful labor, and that was one of the first pictures. And
Oh, I guess.
so married to an obstetrician, and so I'm a Sweden
Oh.
picture choice because of that. So
And 60 methods.
I was kind of like, wow.
All right.
True.
So
And
back-
she finds them interesting.
Yeah. Yeah,
Yeah,
and it was just, yeah.
kind of that historical.
Yeah.
Yeah, I was gonna say, I don't think they do that many forceps deliveries anymore, do they?
That was a little.
Yeah.
They're very well developed fetal face too, like, just like in.
Yeah,
Yeah, the baby was like, this is exactly
It
how I.
has a suction cup on its head instead of a voice.
It's true.
anyway, that, I'm just teasing on that one, but
Mhm.
good, thank you. I have, I'll say that next month, for the March rounds, we're going to have a person who is the director of the, clinic at Hennepin, Healthcare that treats HIV and, hepatitis C, and, they want to talk to us, you know, about that issue in substance use, in patients with substance use disorder, as far as screening, treatment, and all that. So I think that'll be interesting.
Great, who is it who's,
Jesse Powell,
Yeah.
I think they're the, I don't know if it's called the Minnesota Coalition for
Mhm.
Treatment of Viral Illness or something. Anyway, they're the director of some state initiative that's trying to not only treat but education and stuff relating to HIV and Hep C.
I can vouch for him. He's a really great provider. He's helped me fill a lot of my patients with hepatitis.
Yeah, okay.
all right,
Thanks, everybody.
thank you.
Thank you.
Stop recording.
There you go. Perfect.